I'd like to welcome everyone to September Sickle Cell Awareness Month and to our topic this month, which is reducing sickle cell disease related stigma. For many people on this forum, you already know what sickle cell disease is, but for maybe a few community members that may be joining us, I would like to say again that sickle cell disease is a genetic blood disorder that affects the red blood cells. And according to United Nations, over 300,000 babies are born annually with sickle cell disease. Majority of them live in low resource countries. However, even in high resource countries as Canada, individuals with sickle cell disease are still stigmatized and they face a lot of discriminations. Well, could it be because sickle cell disease is a racialized disease? Given that those affected are largely from Africa, Caribbean, South Asia, Middle East, Mediterranean, South America, and so on and so forth. Today, we will hear from our panelists on their experiences, and we will be able to also participate in the discussions. But before we move further, I'd like to provide some housekeeping rules. At the bottom of your screen, you'll see a chat box. If you have comments, you have questions, we ask you to put in there. There is also a Q&A box there at the bottom of your screen. You can also utilize that. Dr. Verhofstadt and myself and the other panelists will be looking on those Q&A, and they will be responding as we move along onto this forum. I would also like to introduce to you the panelists that we have today. First is Dr. Madeline Verhofstadt. She's Associate Professor, Division of Hematology at McMaster University. She's actually the director of the Adult Sickle Cell Program at the McMaster University Medical Center. She also works out of St. Joseph's Healthcare, all in Hamilton. And if I may say one more thing about this wonderful woman, she is actually the brain behind Sickle establishing the Hamilton Wentworth chapter. She felt that there are more and more individuals with sickle cell in this area, and we need to have a group to support them. So she's been on the board of Sickle. She's a very important individual to us. So Dr. Madeline Verhofstadt, we welcome you. We also have Mr. Calvin Lane, who many of you will know as Forge. Forge is someone that is very vocal in the sickle cell community. He shares his experience and his disease, living with sickle cell disease, and the journey he's been through in many fora. And I'm very honored that we have Mr. Calvin Lane gracing us with his attention today on this panel. Mr. Calvin, welcome.
Thank you.
We have Dr. Jennifer Bryan. Okay, I'm sure you all want to hear because emergency room is a big issue. And Dr. Bryan is a staff emergency physician working out of the University Health Network. She's a big part of the 2018 National Conference planning. We were on the planning team together, and she put a lot of input, especially when it comes to emergency room. We know that most stigma we experience in the sickle cell community is lack of educated healthcare providers when it comes to sickle cell. And we sure want to hear from Dr. Bryan on what she has to tell us on how we can improve what is going on in Ontario emergency rooms. So welcome Dr. Jennifer Bryan to the panel today.
Thank you very much, Lanry. I'm looking forward to our conversation.
Thank you. And lastly, but not the least, we have Ms. Lynella. Welcome. Ms. Lynella lives out of Hamilton. She's the first coordinator of the Hamilton Wentworth program. She's been on Sickle board. She continues to volunteer, and you cannot shut Ms. Welcome up. She is loud in our expression of what sickle cell is, what we need to be doing, and how we need to be doing it. And I can tell you, I love this woman's passion. So we want to welcome you, Ms. Linella. And again, I want to thank everyone for joining us and be part of this session today. Welcome.
Thank you.
Now we are expecting, for World Sickle Cell Day, we have invited members of provincial parliament from the three parties. However, MPP Jill Andrews has graced our invitation. I don't think she's yet on the panel. Let me check. Not yet. She's not on the call yet. We will continue her meeting, and when she joins us, we'll give her the opportunity to bring our greetings. Without taking much more of your time, I'd like to hand over to Dr. Madeline Osek. Thank you.
I just have to unmute myself first. Could you see my screen there a moment ago?
Yes.
Okay.
A moment ago, yes.
And now it's back.
Yes.
Okay, so the most important part of today is the panel discussion, but we thought that it would be really helpful to have a little bit of discussion, like some background, just to understand the issue from a few different angles. And so I guess I'll set this up in a way. So this is a huge topic, and for many of us, whether you're a patient, whether you have a loved one who is living with sickle cell, whether you're an advocate for other reasons, or whether you're some combination of all of those. And for me, as a healthcare provider, I really see myself as an advocate, and really have developed close relationships with my patients so that it feels very personal to me, this issue of stigma. So, you know, this is an issue that's close to all of our hearts. Anybody who's on this webinar today knows this personally from some respect. And so I want to say it's a big topic. As I was preparing this presentation, I wanted to be comprehensive, but I know I'm also mindful that some of these things may stir up, you know, emotions, right? Because it's reflecting challenging experiences that many of us have either had or heard about from our loved ones. So I just want to say I'm going to be going through it fairly quickly, and some of it is condensed findings of medical research. So I'm going to be really skimming the surface of what that medical research did, like what's the bottom line of the research project. After I've done this presentation, we're going to be having the panel discussion. And then as well, as part of that, we're going to be welcoming questions, comments from the audience to really engage with this more and talk more about some of the details of it. So, okay. Oh, funny trouble with so I may need to do this in the window like that. Is that view okay for everybody?
Yes.
I'm just going to get rid of this notes bar. Okay, so why are we here today? September is Sickle Cell Awareness Month, and so this is a really important time to be talking about all this topic. Any talk about sickle cell starts with reminding us about, you know, why do all these problems arise? So I'm not going to spend a lot of time on this, but we do know that this is a genetic condition. It primarily affects people whose ancestry is from areas where there was or is a lot of problem with malaria. And so that somebody who's a carrier generally wouldn't have any medical problems, but somebody who has inherited hemoglobin S and or other combinations from both parents then would have sickle cell disease. And this does cause anemia because of the blood cells breaking down. And the part that's really going to be impacting on what we're talking about today is the sickling and the blockages that can happen, resulting in terrible pain in the bones and throughout the body. So this is a picture of a little one who's got dactylitis, because when we're young, the bone marrow in our small finger bones is still has blood flow coming through it, and that blood flow gets blocked and we can see it. But as somebody gets older, we can't see this inflammation in the same way, and a lot of the times the pain and experience is invisible. So sickle cell disease really ends up being a multi-system disease. A lot of complications can happen, although thankfully most people don't have, don't have all of these issues. So while there are a lot of chronic problems that can accumulate over time, really I think our focus and what becomes then an issue in the sense of the stigma is more related to the vaso-occlusive pain episodes, otherwise known as pain crises. So these are some images that are giving us a sense of what that experience is like. It's something that only someone who's experienced sickle cell pain really truly knows. These are by a very talented artist who lives in the United States, who's living with sickle cell, named Hertz Nazaire, showing, the feeling that somebody is having when they're experiencing these crises. So when we talk about someone having a sickle cell crisis, one of the issues that's going to come to mind, and one of the experiences that people has had, is experiencing barriers to care. And this is an unfortunate thing that goes hand in hand with experiencing vaso-occlusive crises for people worldwide. And this was a very useful but sad illustration put together by a colleague, Paula Tanabe. So where we have someone who has sickle cell, we have them coming in potentially for frequent visits, maybe the clinician, so the doctor or the patient, but mostly the clinician, may have a knowledge deficit. There's this stigma, which is our focus today, either chronic pain or the need for opioids that's leading to the perception of addiction. And very importantly, that's going to figure very prominently in our discussion today, is the racism and how that intersects with all the other parts. So what is stigma? I spent a lot of time digging around for a definition of stigma that I thought applied to our discussion well today. And I couldn't find a good one. So this is my definition. So what is stigma? Negative assumptions and stereotyping that lead to people being ignored, excluded, or treated poorly. So this is just my kind of general definition. And what does it boil down to? It's a form of discrimination. Somebody who's taking one aspect of you or a few aspects of what they think you're all about and discriminating against you based on that. In this situation, stigma can lead to disadvantage and inequitable social and health outcomes. And this is what we're going to be talking about today. Stigma happens in institutions, so healthcare organizations themselves can have stigma, in individual relationships and interactions, and sometimes this is the nurses and doctors in the emergency department or in other clinical settings. At a population level, of course, whole population can have a stigma against different conditions, and a very high profile discussion has been going on in North America over the past few years about mental health and stigma, like reducing stigma about mental health issues. And then importantly, but we may not think about it too much, is internally. So someone can internalize that stigma and then it affects their self-worth and value. So we're going to dive right into some of the research about stigma and sickle cell. And once again, I apologize for the view here that my slideshow function isn't working. But hopefully everybody can see this, and I'm going to read out the high-level summary, the main findings of this research. So you'll see these researcher names coming up a lot as I'm going through the research. Paula Tanabe was the person who put together that circle of barriers to care, and Sophie Landskron in conjunction with Carlton Haywood at Johns Hopkins. So this is a group that does a lot of this research. And importantly, Carlton Haywood is very public about having sickle cell himself. And so like, I think that's really amazing and something that's so important. And you wonder, you know, that this, somebody who's experienced this themselves is going to know exactly what questions to ask, you know exactly how to approach these questions. So this group took a look at databases from across United States and looked to see what the impact of race and sickle cell disease was on wait times. So anybody with sickle cell can tell you, I was in terrible pain. I told them I'm in terrible pain. And then they made me wait. So, and then you think, well, maybe it was just the day, maybe it was just, you know, they had a lot of really critical cases coming in, that kind of thing. But this is where they took thousands of visits across the country and kind of boiled down to what was the answer. So overall, people with sickle cell waited 25% longer than the general patient sample. So that includes people coming in with a car accident, that includes people coming in with a sore toe and everything in between. What they then were able to do that they can do in the United States, but we can't currently do in Canada because of lack of race-based data uniformly across the country, was they looked to see what impact race had on that. And it turned out that the race had a big part in it. So they waited on account of, related to when they took race into account, that was a big feature. Sorry, I'm angling this the wrong way. The other thing that they looked at was comparing sickle cell pain to somebody who had had a long bone fracture, like if you had fractured your femur, which is the main bone in your upper leg. And somebody with sickle cell coming in with pain and somebody who had fractured their leg, this person with sickle cell was waiting 50% longer than the person who had fractured their leg, even when they accounted for the triage score. So they were both placed at the same priority when they arrived in terms of this person needs to be seen quickly and this person needs to be seen quickly. There's something in Canada called the CTAS score for that. And still the person with sickle cell waited 50% longer. So I like this bottom line. These data confirm patient anecdotal reports and are in need of intervention. So we're taking this from individual patients saying this isn't right, I waited too long, and we're actually pulling data to substantiate it. Again, this is American. We'll talk more about Canadian setting as we go. This was another interesting survey. This was much more limited, where they surveyed and did focus groups with emergency department doctors in a particular part of North Carolina. So like take the findings with that grain of salt because it's a certain region. But they did surveys and interviews with emergency doctors, and this was published in 2019, so it was probably done in 2018. Less than a third of the providers were aware of the sickle cell guidelines. When they asked the providers on the survey, you know, what are the barriers to sickle cell patients getting good care? They said patient behavior. I don't know what that means. The opioid epidemic. What does that have to do with somebody with acute sickle cell pain? Overcrowding. This starts to get at some of the issues that probably we have here too, and concern about addiction. When they did focus groups, they acknowledged again high patient volumes. So the emergency department is a very stressful, busy place. Dr. Brian, my hat is off to you. There is no way I could ever do that job. Lack of sickle cell care protocols and poor communication among providers. And lastly, here's the first time we're seeing about stigma, okay? So I have to say the NHLBI sickle cell guidelines have been around for almost 2 decades. The most updated version came out in 2014. So if by 2018, these emergency doctors weren't aware of it, then that's a problem. Now, as of 2019, 2020, we have we have additional sets of guidelines, which we'll be talking about later on, which is from the American Society of Hematology. So what did the authors conclude? Again, this is Dr. Tanabe and her group. Need for increased use of proper guidelines, individualized pain protocols, and electronic medical records. So kind of that piece about communication. Okay, so, you know, looking at that emergency to doctor survey, they're talking about, you know, this perception of addiction, And it's clear that these physicians don't have the knowledge background that they need, because they're not, it's not only that they don't have the guidelines memorized, which nobody would be expected to memorize all the guidelines, they aren't even aware that it exists. And they're acknowledging stigma as well. No mention of racism, but that's coming. Okay, so this just came out. I think it just came out like last week. Emergency department utilization for patients living with sickle cell disease. Okay, so it's kind of got a big wordy title. But bottom line was, they surveyed some patients who were participating in another study. So this only involved less than 200 patients, but they surveyed them about their emergency department use and whether they were likely to delay going to the emergency department when they had pain. And 2/3, 67% of the participants reported delaying visits to the emergency department. Why? Well, stigma. Those people who had frequent pain episodes were less likely to go right away. If they had lower healthcare satisfaction, right? Those things go hand in hand, and more frequent ED visits. So here again, we have stigma, you know, so, okay, so what about stigma? Well, stigma not only means potentially longer wait times when you're there, not inaccurate treatment, but now, in fact, people aren't even seeking the care that they need, potentially influenced by their past experiences of stigma. And so it becomes really, you know, sad and disappointing, and wondering how we can fix this. This study, I don't know any of these authors. I'd be interested to know if any of the panelists or any of the webinar attendees are familiar with the group who did this study. This is the only Canadian study I'm going to be referencing today. And it was done, I don't have the reference here, but it was done, I think, over 10 years ago. But the findings are so poignant. What they did is they interviewed 10 parents, caregivers, mothers, looking after children with sickle cell disease, just asking about their experiences. And they broke it down into daily caregiver coping, which they thought of as the micro level, community views of sickle cell such as stigma, which was a kind of the next concentric circle out from that, and then systemic sickle cell healthcare provision. And so what did the mothers say? They commonly reported several daily coping challenges: fear of their children's death, separation anxiety, so when they were apart from their child, they were worried about them, loss of control over life, helplessness, and loneliness or isolation. Sickle cell stigma interacted with racism, contributed to social isolation, and prevented families from organizing as a group. So this was, you know, SCAO and SCAGO are the two main organizations that I'm aware of in Ontario doing this work. They have started to build over these past few years, but it's hard to organize when you're just getting by, when you're having your own family struggles. So moving on from this, they came, all mothers perceived racism as a salient factor behind inadequate mainstream sickle cell healthcare. All of them, all 10 mothers brought this up in their discussion. And they had some recommendations from this about how to improve things, including sickle cell stigma. So I'm gonna go pretty quickly through the rest because this is gonna form the foundation for what we're talking about. Coming on this topic of racism, this is a study from the United States where they surveyed families. In this center, they surveyed the families and the caregivers. In this center, 92.6% of the patients and families identified as Black, while 94.1% of staff identified as white. Here I am, white woman doctor, you know, I should have started off at that. I know that I'm learning about all this. I know that we need to increase equity in our healthcare workforce. This is a really stark imbalance, right? If there's any sort of racism in our society, this imbalance is going to set things up poorly. Now, furthermore, the healthcare workers were a little bit clueless about the racism. So when they asked families whether there was race affecting the quality of healthcare, they said, yeah, 50% of them said yes, whereas the healthcare providers dismissed that idea. Now, interestingly, the healthcare providers, when they were asked, oh, do you think that the sickle cell patients get inequitable treatment in the inpatient setting? So if they're admitted to the hospital, they were more likely to say yes. So they realized that there's something going on, but they maybe not labeling the problem very well. I was trying to find a visual to help summarize all the different layers to this problem. And in some ways, this visual is a bit overwhelming, but I thought it was useful. When we're thinking about stigma, there's all of these layers. It's kind of like an onion, right? And then there's all this stuff going on around the situation. So there's what we said, internalized stigma, which I didn't go into much here, but we can discuss. Just that idea of somebody feeling less than, or internalizing that sickle cell somehow makes them less worthy. Then there's the experience of thinking that they might be experiencing discrimination and actually experiencing discrimination. And there's probably some stress in terms of not knowing when that's actually happening. And then there's all of the layers in society. And then there are all these other things going on too, right? Depending on your other aspects of your identity, your race, your class, your gender, your level of ability, and any other identity related to sexual LGBTQ identity as well. And there are all these levels that we need to work at to fix this. So when we think of all of this, I put together this slide for a presentation a couple of years ago, actually for the SCDAC one. And I pull it out often now because I think it's so important. It reflects so much the experience that, I walk together with the patients who I care for. Not always. Sometimes the hill is flatter. Sometimes the boulder is more light. But in the darkest times, it can feel like this, right? So how do we move past this? Well, it's a lot of work, but it's worth it. When it comes to stigma, there's all these levels that we can work at. So starting with educating, empowering the patients and families to really take an active role in their care, to feel as though they have allies, people that they can turn to if they're facing this discrimination and stigma in their healthcare. So this was a study where they interviewed caregivers about stigma, and it's the caregivers of adolescents, so kids who are likely in their teens. And this isn't numbers, this is qualitative research, so like interview-based research. And so these caregivers said that the stigma may affect individuals with sickle cell across multiple settings. And so that included not just the medical setting, but also schools out in the community. So we think about all the places that we can experience discrimination. And these caregivers had great ideas. They thought that any interventions should utilize technology, social media, advertising campaigns. And they said support groups for patients with sickle cell may help decrease stigma and validate patients' experiences. So there are, a lot of great ideas, and the doctors don't have the ideas. I mean, we can guess. We need to hear people's stories. That's how we move forward on all of this. I was not aware of this report. As I was doing my prep for this session, I came across this from 2019. This was before she was famous, Dr. Teresa Tam. Well, she was famous, but not in the public eye as much as she has been during COVID. In 2019, her big annual report, the theme was stigma. And I didn't come across any mention of sickle cell, but it's a really, really in-depth, well-written report. Why I bring up this slide here is that it helps to break down the drivers of stigma, different types of stigma, how it can manifest, what the experience is like, and how that affects people's outcomes. And down here, it again brings up all the layers. So at the individual, interpersonal, institutional, and population. I just wanted to highlight this report because it's this great work and resource that's out there, and it's with a Canadian focus. And I think as we do our advocacy at provincial and national levels, you know, we want to kind of refer back to these official government documents and say, hey, you know, you were talking about stigma, well, sickle cell is in there. So when we go to the next level, thinking about healthcare providers and hospitals, this is where I'm going to really go through fast, but it's just to highlight, there's a lot of focus on the emergency department, because for all of the factors that we said, you know, you're meeting a healthcare provider for the first time who you've never met before, they don't know you, they're a generalist, they're not a specialist in sickle cell, right? There's all these layers, but we can make this better by educating the healthcare providers in a number of ways. So within Canada, some of that has taken the form of information sharing through the Canadian Medical Association journal, for example. But we're in 2020. People read journals, but you know, social media and web-based stuff is sometimes more impactful. So this was done a few years ago, but it's just one example of something that was done, which is a podcast that, from what I understand, was very well received and well utilized. I like this. This I came across, Johns Hopkins Nursing. Sometimes it's just as simple as a profile on a website. When pain doesn't show, doubting nurses should check themselves first. I love this, right? And so if you share that with all the nurses in a department or in an education program, you can really get at the root of the problem quite easily. This is a really impactful video. It's getting a little bit older. This was put together by Sophie Lanscron and Carlton Haywood, the team from Johns Hopkins, who I mentioned. This video shows, so, you know, getting away from knowledge, okay, we can read a guidelines and know what to do. What does all this really come down to? It comes down to understanding people's stories, understanding experiences, having empathy for what somebody is going through. So that's what this video conveys. And they showed it to healthcare providers and then studied it to see how it impacted them. And it was great. They had less negative attitude toward people with sickle cell. Why would you have negative attitude towards someone with sickle cell? I don't know. But if they had a negative attitude to start with, it was less. And they had more positive attitude, right? So this is just a really simple 8-minute video, can have a huge impact. This was another recent study, I believe, from last year. This is more for the healthcare providers who might be on the call. This is now mandatory reading for any learner who comes through our sickle cell clinic. This is the same group again, Carlton Haywood, Sophie Lanscron, their group at Johns Hopkins. They said, hey, wait a minute. When we read charts of patients, there's these words that get sprinkled in sometimes about, you know, patient states, or, you know, I'm gonna come to it. So what they did was they had a snippet from a patient chart. This was all fictional, but, you know, they had this fictional patient where it had stigmatizing language that made you maybe judgmental toward that patient. And then they had another one that was neutral, that just said, patient has pain, patient took this, etc. I'm going to show you. And then they looked at, and sure enough, people had less prejudice against the people where they read a chart with and this is a big problem in the hospital, right? Because if a patient gets a reputation, we hope that this never happens, but it's possible, and it's in their chart, before you even meet the patient, if you open up their chart and it's got this kind of language, oh, you know, we're worried about addiction, blah, 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 that healthcare provider may already be biased against you before they have even walked in the room, which is so inappropriate. So this is the stigmatizing one. Mr. R is a 28-year-old sickle cell patient with chronic left hip osteomyelitis. This is all medical-ish, but you'll pick up where there's negative connotations to things. Left hip osteomyelitis, who comes to ED stating he has 10 out of 10 pain all up my arms and legs. He is narcotic dependent and in our ED frequently. So you see they're kind of planting these seeds. At home, he reportedly takes, etc., with the medications. Why reportedly? Over the past few days, he says he has taken tube tabs why he says? Just he took it. About 3 months ago, patient states that the housing authority moved him to a new neighborhood, and now he has to wheel himself in a manual wheelchair up 3 blocks from the bus stop. So, you know, that idea that, you know, he's in subsidized housing, he got booted out of his place, like all of these things where you're planting seeds of doubt about this person's reliability. So instead, Mr. R is a 28-year-old man with sickle cell disease. He's not a sickle cell patient, he has sickle cell disease. He comes to ED with 10 out of 10 pain in his arms and legs. He has about 8 to 10 pain crises per year for which he typically requires opioid pain medication in the ED. So again, not saying, oh, he's always here, just saying he has this problem, he comes to us, right? And so these are important things, really subtle, but important things. Okay, so moving on from patients to healthcare providers and hospitals to higher level initiatives. In Canada, we haven't had much so far. This was in Ontario a few years ago and ended up getting kind of shelved, but it's still a document that's available. This was an initiative to try to apply a standard of care for sickle cell emergency department visits across the province. So where there was kind of a pathway that was supposed to be followed and certain ways in which, so for example, patients were supposed to get their first dose of pain medication within 60 minutes of arriving. This is still something that's on the shelf, but we're hoping to brush it off. Then we think about things like guidelines. So we have in need of a little bit of updating the Canadian consensus statement, which is some recommendations about care for sickle cell. We mentioned the NHLBI guidelines, and then more recently has been the American Society of Hematology has come out with some guidelines. So nobody, if you don't know much about sickle cell, it's okay. If you're looking after someone with sickle cell and you're not sure what to do, it's okay. All these resources are available. Open access for, so just a Google away. Okay, racism, such a big topic, so important, so under-recognized overall, and particular with sickle cell, and finally starting to get some attention. This is at all levels. This was just from a couple of weeks ago in the New England Journal of Medicine, When Actions Speak Louder Than Words, Racism and Sickle Cell Disease. And without going into all the details, this is focused on the United States, but it's the same in Canada. We have to address the interpersonal racism, and that's in the healthcare system, whether it's implicit bias training, open discussions, education about racism. Every healthcare provider needs to be aware of this, especially if it's somebody who's white or coming from a privileged background, right? Otherwise, you say, oh, well, yeah, they don't get the same treatment as everybody else. We don't know why. Dismantle institutional racism and impact on structural racism. And some of this is things like making sure there's universal screening for sickle cell disease, making sure there's federal funding for comprehensive sickle cell disease centers, same issues we have in Canada. So here we are, back with the boulder. But it doesn't need to be just one person pushing that boulder up the hill, right? We're all in this together. And the group that you see on the panel today is just one small drop of who is engaged in this work across the country. And nobody can do this alone. And even more so, what you need is people coming at this from different angles. The patient, what's your experience? How can we help you? How can we work together? The healthcare providers, the advocates, the policymakers, all coming together to make this better. So with that, I want to wrap this all up. Lots of food for thought, and I'm really looking forward to discussing with all of you. So
thank you, Dr. Verhosek, for that informative presentation. So I think we will, for me, I think you just hit the nail on the head. We've also understand that not only from the Black community, also other racialized communities, there's a lot of discrimination, stigma going on, and this is part of the initiatives that we're taking to even, we are approaching the government on reviewing racialized communities' health issues with racialized lenses. So I think your presentation is driving home more that this is a huge problem that we need to really, really step up, even in our country, Canada. Thank you for that presentation. I'll let you continue.
Yeah, absolutely. So just gonna bring up some questions. I'm interested at this point in obviously getting reflections from our panel members. And I'm going to start with Kevin and Lynella. You know, it's such a big topic. It's so personal. And the other thing I should actually, just to frame our discussion as well, it is very personal. So I want to emphasize to everyone, don't feel that you need to, you get to decide, if you want to take a pass on a question, if something feels too personal or you need a minute, just this is a pretty casual discussion with a few dozen people listening in. So yeah, let's start maybe with you, Kevin. So as you listen to all of this, what's coming to mind for you? And with those who are listening, what would you most want to say about your experiences?
Well, to begin, I mean, first and foremost, everything you wrote up there was really well said. It was well documented. There are some points there that I even had to take for myself. And again, I'm going to elaborate on a few of them. The most important thing is, yes, stigma. That word stigma, I wanted to also agree with you. When I was looking for the definition in the dictionary, I was like, hold on. It doesn't really touch on nothing that really relates to us with our sickle cell disease. As I'm hearing now, we call ourselves sickle cell warriors. So it doesn't really touch on that, but I like your definition. Your definition really, sheds more light on it. A couple of things I wanted to point out from the stigma. It's the youth. And what I mean by the youth, I don't mean 18 and under. We have Sick Kids Hospital here in Canada for that. It's more for the 18 and up. There's a big, for myself, I do notice that transition. Once you get from 18 and up, a little bit lack of more knowledge and more conversation that goes out to those individuals. But these people still have to go into the workforce. They still have to live their lives. And there's no real support verbally for us to find for these young people to get through that transition. The stigma when it comes to that is that, you're older, you can handle it. You should be able to deal with this. But you have to ask yourself, have they gone through therapy? Have they spoken to family members? Have they spoken about what they're going through at the younger age? A lot of transition doesn't even happen there. I myself have two wonderful, beautiful children. Unfortunately, my son who has SS disease, he has to get transfusions every month. But you have to question, because they're missing school. Now you're going to go into university, college. Now it's more independent, but you're going to be missing school. How does that reflect on these individuals? Now they're going to go to work. You miss 4 days because you have a sickle cell crisis. How does the workplace look at you? So there's a lot of things that sickle cell individuals have that they have to deal with, which creates all this stigma like you were explaining, but it's grander to me, I guess what I'm taking away from this is just more or less that there's a lot of work we have to do in our community. My biggest regret is that a lot of our information comes from the US. It's a big regret for me because when you immediately, let me rephrase that. For myself, when I started reading about sickle cell anemia, learning more, I'm born in 1979, that means I'm 41 years old. You have to understand, in the 70s or the 80s, they didn't even know about sickle cell. They had told me before the age of 18 that I was going to die. Doctor walked into the room and explained that they don't understand this disease and that you will pass away. So from 18, no, not even 18, from 16 or 15 years old, I started living my life like it was the last day. So I started not paying attention to things, not caring about tomorrow. I could have led myself into a world of, crime or regret or of that. But thank goodness I had a great support system. But because of that, individuals need to understand that we're already setting ourselves up for failure without knowledge of what's happening within the individual. My biggest regret, again, due to the fact that the US, it always shows us sickle cell as a Black African-American disease. Yes, primarily, I understand that. But that also creates a stigma for outsiders to say, well, that's a disease that you're dealing with, not us. We needed to break that barrier. And because of that, we need to be able to explain that, people from all walks of life, India, Asia. I know someone from Afghanistan that has sickle cell anemia. I mean, because of colonialism and people been traveling all over the world, there's a lot more people that, Black people are everywhere. So because of mixing, a lot more people might have sickle cell. So my biggest regret is that we're only using the American knowledge. Now, why I use that as an example, my wife is from Guatemala. She's Spanish. So I met my wife and I thought that was great. We had children. And then a couple of years ago, Canada had, I think we created a situation where every child gets screened. Every child gets screened within Ontario. It started with Ontario. Once my second child was born, they started to screen, and then we found out my child had sickle cell. Then you keep going backwards and we find out my wife has the trait. But my ignorance, due to the fact that the knowledge they were giving me, I thought, oh, she's Spanish, she can't have it, right? So we need to change the narrative. We need to understand that there's more. We need to explain that sickle cell affects not only African Americans, but anyone can be that can have it at this moment. So that's really my stigma right now about the youth, and more about the educating ourselves to let them know it's a broader scale of individuals that can have this disease, and to prepare yourself, because the more you know, it's better, right?
Yeah, fantastic. Thank you for that. Lynella, what's your thoughts on stigma and sickle cell and what we've been discussing?
Myself, I did some research before to prepare for the panel. So what my definition of what stigma is, it's the rejection of people with a certain health conditions based on a negative stereotype. In my many years of living with sickle cell disease, I recently started experiencing more negative stereotypes in the workplace and in my hospital stay, where I had to call in help because in that environment I wasn't able to really advocate for myself properly and accurately. I find that Dr. V, I also looked up some research online on the John Hopkins one where the doubting nurses, needs to check themselves. I've had experiences with so many doubting nurses and doubting doctors, and I want to refer to the quote you used, the point you used, where the fractured legs is more believable than the sickle cell patients walking in with the sickle cell pain. When I was doing the research, it shows that if someone's coming into the ER with sickle cell pain, because we are masters of concealing our pain, because we had so much years of experience of concealing how painful our pain is, we are not found to be very believable upon presenting in the ER that we have pain 10 out of 10. But if someone shows up with a fractured leg, the face expressions is there, the sight is there. So it's things that can see. Sickle cell pain is not something someone could see. So we are not believable most times when we walk into the emergency department. I've had experience where I've been into the ER and I've heard the doctor said, well, just give her what she's here for and send her on her way, because they don't see the expression of my pain, my face, in my gesture, my body, my way of talking, or the way I'm presenting myself, because they look for those things. So it's the stereotype that comes with the stigma that makes it hard for patients with sickle cell disease to be believed upon entering the ER. If I wasn't part of Sickle Cell Awareness Group Ontario and had a voice, I would have been shunned upon and shut out so many times. But I sometimes think about the people who don't have the voice to express themselves and say what they want and advocate positively for themselves. So it all has to go back to the environment, the doctors, the nurses, the knowledge, educating ourselves. I find a lot of nurses will ask you these questions like, how long you have sickle cell disease? And I'm like, is that a serious question? Like, really? And I'm like, I think of a way not to be a smart a-hole about it and, be nice. But these are little things that you stumble upon and think, well, we are so far behind than I thought we were, originally. But into sum up, what am I saying? It's because we manage our pain so well. I find even at home within my family, people won't even know I'm sick until the last absolute minute when I check myself in the ER, because they was like, "Well, you look just great. I saw you 2 minutes ago." But we're masking the pain. We're masking the pain. We feel ashamed. I will speak for myself. I don't feel to burden my family or my parents or my siblings with my medical issue because they have their own problems. So I wait until absolutely last minute for myself, because they may say, "Well, we just saw you. You look great. Like, how can you be sick 2 minutes later?" So those are the things we have to work on to make it clear that we are great at hiding this pain we have to live with every single day. And we just need to be believed when we say we are in pain, because now the pain is actually to a point where we ourselves cannot mask it no more. And that's that's all I have to say about it. It's just believing us when we show up. It's just having to believe us, because we all look great as persons with this pain that we are carrying around that no one can see. A broken leg, you can see. A broken arm, you can see. A fractured skull, you can see. A stab wound, a knife wound, you could see those things. But if I'm walking into an ER looking this good, and they're like, "Well, nothing's wrong with you. You're not scrimmaging in pain. Nothing's wrong with you. Why would I believe you?" And that's the stereotype I face sometimes when I go up and when I end up in the ER.
Can I chime in on that one to add?
Yeah, please.
That I agree with you 1,000%. First and foremost, Linnell. There was a moment I was working at a specific job. I was working at the bank, and unfortunately, I just couldn't handle the pain anymore. I went to my manager and said, I do have to leave. So I left, but I drove myself to the hospital. Ended up staying in there a few days. The word came back. One of my other managers were saying, "Oh, how could he have been sick? He looked so good," because I dress in suits and whatnot. They said, "Oh, I think he was using this as a crutch." So I learned from that. And the next time I got sick, I called the ambulance right there so they can drag me out on a gurney, because I didn't want to be embarrassed the first time. But I realized sometimes you have to show them to understand that you're really going through these situations. Another example that I'd like to give was on Father's Day this year. Unfortunately, I had an acute chest syndrome situation. A little bit more about myself. Unfortunately, in 2007, I ended up in a coma. I passed away. They had to resuscitate me. I ended up having acute chest syndrome. I was in Toronto General Hospital, great hospital. Thank you, Dr. Ward, and everyone else over there, keeping me alive. But Father's Day that just passed, I was in my house, in my room, sleeping, woke up in the excruciating pain. I had kind of nudged my wife, and she says, "Oh, I'm not feeling too good," or we just had Father's Day. So I waited an extra 5 hours before I woke her up. I was in excruciating pain, but I said I do not want to put her out of her way. Wait till the sun comes up a little bit, so then she can maybe be able to assist me a little bit more. It's a lot of things we as sickle cell patients go through, because we don't want to get people, out of their comfort zone or put them in inconvenience individuals, and it's something we have to deal with on a daily level. My son he's very stoic. So even when he's in pain, I have to ask him over and over again, because his pain level is different than someone else's. But if he stubs his toe, it hurts. But our sickle cell pain is so different. It's hard to explain what we're going through at that moment. But you're right, because we don't have blisters or bleeding from the nose or anything of that nature, they tend to question the realness of our pain. And that is a very big issue, especially when you go into a hospital and they start questioning, why do you need these medications? So I don't know if it's the triage nurse who starts that paper and pen, writes it down, because from your examples, doctor, a lot of this starts from somebody writing it down. So it's that first interaction of who writes it down is going to conduct the rest of your stay in that hospital, how they deal with you going forward. And that's where we need to change. If we're not voicing for ourselves, then who would? Right.
So many amazing points that you've both made, and so many different areas for improvement, right? I'm interested to get Dr. Bryan's perspective. I often feel for my really amazing colleagues in the emergency department when we have these discussions, because a lot of the negative experiences that patients have are unfortunately in the emergency department. And it's not to say that there aren't a lot of incredible people working there, but there's a lot of room for improvement overall, just based on stories, right? Stories and experiences. So Dr. Bryan, why don't you, fill us in from an emergency department physician perspective. When you hear these stories, mm-hmm. what do you think of in terms of what needs to be done, what can be done? And maybe you can tell us a bit of about what you have been doing as well.
So when you talk about these stories, these anecdotes, I see parallels there to what you're saying about if you are telling somebody you have pain, right? If someone is telling me that the care they're getting in the emergency department isn't making them feel safe, isn't making them feel comfortable to come back when they need help, then that's real. Right. I think that Dr. Verhosek, the data that you showed is very helpful in terms of trying to drive policy and make change. But it's those individual stories that resonate the most. It is sickle cell disease in the emergency department is facing a storm of stigma and racism all wrapped up together. Coming into an emergency department in an unfamiliar situation with a crisis that can't be seen, that can't be tested for when you're having pain, and trying to advocate for yourself while you're going through this kind of crisis with somebody that you're just meeting. An incredibly difficult situation at the best of times. So I definitely, I share I want to say empathy. I don't think empathy is quite the right word, because I can't feel what you feel when you come into the emergency department, right? I certainly have heard the same things that you've been describing. So Kevin and Lynella, from my patients in the emergency department, and from my colleagues as well. So I do hear the same ideas of not wanting to burden others when you're feeling unwell, right? I do hear the descriptions of trying to mask pain, of trying to cope with pain in ways that are different than what many of my colleagues are used to seeing for patients in pain. So it's not unusual, thankfully becoming more unusual, but still not unusual for me to hear from colleagues, oh, this person they're sitting there, they're on their phone, they're having a sandwich, they look fine. And there is a big education piece that goes into saying that's a way of coping with pain. If they're telling you they're having 10 out of 10 pain, and they're using their electronic devices, or they're eating, or they're talking, that is a way to manage this pain. That is not a sign that the pain doesn't exist, right? So there's definitely a big education component that needs to happen. That has been happening slowly, bit by bit, clearly not quickly enough. Some of the articles that Dr. Verhosek was talking about have started to percolate into the emergency medicine mainstream. That recent article from the Annals of Emergency Medicine that you posted, Madeline, the Annals of Emergency Medicine is probably the most read emergency medicine journal in the world, I would say. And that sickle cell is getting the attention that it needs in the Annals of Emergency Medicine is very promising. There was also a recent article in the Canadian Medical Association Journal, a first-person patient perspective by someone I think many of you in the audience will know, Serena Thompson. And that article, I was very encouraged to see, was being discussed regularly in the emergency department, was being passed around, was being shared over Twitter and social media and all of the rest. And it's those kinds of personal stories and honesty about what everyone is facing when they're coming to the emergency department that is hopefully starting to have an impact. The other things that I'm excited about in the emergency department, I think that knowledge and training, of course, are important, but it is a difficult way to really build up the base that you need in order to have the kind of response from healthcare workers that you need when you're in crisis. The other two components that I see as very helpful, one is the slow but sure shifting of the demographics of the physicians and nurses and other healthcare providers that you're seeing in the emergency departments. The way that I became involved in sickle cell was through the Black Physicians Association of Ontario. And through the work of Dr. Anya Noram. In the Black Physicians Association of Ontario, the first meeting that I went to was the first time that I had ever been in a room full of Black physicians. And the power that comes behind that is remarkable and gives me a lot of hope, hopefully gives you some hope as well. There is a lot of work happening now in encouraging Black medical students to pursue careers in specialty medicine like emergency medicine and hematology. And there's a lot of work being done in the community to reach out to high school students and undergrad university students to try to address some of the disparities that lead to a loss in representation as you do move up in higher education. So I think that's very important work. The other thing that I'm excited about is trying to build in solutions in the emergency department. In my emergency departments, for example, so through the University Health Network, and that's the Toronto General and Toronto Western emergency departments, we have a series of what we call order sets that we use. Those are a list of treatments and tests that are considered the best practices for certain presentations in the emergency department. Sometimes those are very common presentations, and sometimes they're quite rare presentations. We, like many emergency departments, have a specific order set for addressing sickle cell pain in the emergency department. Now, is this an order set that is perfect? It is far from it. But what we're doing now is working with our hematologists, including Dr. Jacob Pendergast, who many of you know, as well as actually Serena Thompson, who I mentioned earlier, to revise those order sets, to try to make them more consistent with what's needed when a person comes into the emergency department in a crisis. Having things that don't necessarily depend on the knowledge base of the first person that you see when you come into the emergency department is a bit of a safety net, right? So to say, as an institution, these are the protocols that we have in place. These are the things that we know are consistent with the guidelines that Dr. Verhosek had shown earlier in her presentation. These are the things that our representation in patient input are saying are important. And so I think that those three things from an emergency perspective are what we're looking at in moving forward. But just like Dr. Verhosek had mentioned, the most important thing in all of this is the perspective of the patients and the families who are living with sickle cell. And none of these steps forward are going to be helpful if it's not very much guided by you. And so I'm very appreciative to everyone who's been giving feedback to your physicians, to your nurses, to your hospitals and health centers. It's frustrating to have to give feedback to say when things haven't worked well, but it is incredibly important and it is incredibly brave. And I thank you very much for that.
I love that. Yeah. You know, I love that you're doing the revision of the order sets with direct patient input, right? That should be the standard of how we do these things all the time, but especially when you have a group of people, of patients who have experienced so much stigma and discrimination. I heard a quote this week. I don't know if it applies so well, but they were talking about restorative justice in the criminal justice system. And it was somebody who had, who had been injured, and the person who had injured them had been convicted, and then they formed a friendship. So it's kind of different. But the interviewer said, well, isn't it strange that you're friends now with this person who attacked you? And he said, strange is only unusual when normal isn't working. And so not that having patients contribute to an order set is strange at all, but it's not the usual, you know, that wouldn't be standard at a hospital, but it should be. And this is a situation where these kinds of collaborations are crucial. Thank you for all of what you do. And it's so important to have allies and people within the emergency department who are so knowledgeable and passionate and collaborative. I think after this discussion, you're probably going to have a lot of people reaching out to you. Comment, yeah.
I'd like to chime in again. There was something you said wonderful. You explained, you know, I can't empathize with you due to the fact that I'm not going through the pain. And I feel that non-sickle cell patients or any person that's going through chronic pain, I feel the best example I like to give to people, if you're not going through it, think about mourning when somebody passes away. Now, when you mourn, there's many ways to mourn. There's bawling, there's reading, walk, whatever you do to mourn, but you're dealing with that situation. That's how I'm dealing with it. It might not look contemporary to you. It's not the norm in your way, but it's the way we deal with it. My son has to be on a computer and watch TV instead of taking pain medication. So for him to avoid to take the pain medication because we want to see if what's working, that, you know, we try other methods. A lot of times we try to get our mind off of the pain. Yes, we use television. I might be up at 4 in the morning watching TV until 6 in the morning. My wife is wondering why, but now she understands. We have different coping mechanisms, but I like to use the example of mourning. You don't question a person for how they mourn. You shouldn't question us for how we deal with our pain, you know? And I think that's across the board. Another thing Lanella said about when we went to the doctors and the nurse was like, what's sickle cell? I had that same experience, but it was with my son. We went to the hospital and the doctor said, oh, how long have you had sickle cell? I said, we are leaving the room now because I need him to stay alive. I've had that experience where they asked me in the hospital that I don't frequently visit. They asked me the same question, how long? I said, you know what? It was wonderful to meet you, but I need to leave because I need to stay alive. That questioning of when they ask how long have you had it, that right there tells me you're not experienced and it's not your fault. I don't blame the doctors for not knowing. I just know that we need someone experienced, because the best type of, for myself, the best type of care is when they listen to me. When you are not listening to us about how to deal with this pain, unfortunately, a lot of us, or myself, I should say, I go high with the pain meds and slowly or quickly reduce them so I'm comfortable. A lot of individuals like to put us on one of those, I'm not sure, doctor, what it's called.
PCA.
Thank you. Yep. That doesn't work, because by the time our pain or we fall asleep, we wake up, that pain is at a level 10. Now we have to wait every half an hour for it's just working backwards. Mm-hmm. It's when a doctor comes in and says to me, what will work for you? As long as I'm in the hospital, you can maintain and watch us, and you can make sure that we're in a safe environment. That's why we came to the hospital. A lot of sickle cell patients don't even want to go to the hospital because of these stigmas, because of the care they're getting. So now, how many of them are suffering in their own home? Right? So we need to get away from all these, stigmas and indications of racism and everything else, And again, it's these types of discussions that give knowledge, because you guys are the doctors, but we are the patients, and we're dealing with it. And we realize that there has to be a synergy. There has to be a relationship between A and B so that they both work. There's an old saying I like to use is one hand washes the other, and they both wash the face. So you need them both to make it work out,
Wonderful. Incredible insights and observations. And, that issue about coming to the hospital when you're at your lowest point, right? And to be faced with someone who doesn't know what they're talking about. I like your response, but, I wonder how that ends up adding to your stress as well if you're needing to go somewhere else. And it brings to mind, I'm just going to pull up the Q&A here as we enter the last 15 minutes before the webinar ends. There's a question here from Kieran. Even in the Caribbean, with Black dominant population, we experience this stigma, including racism. Shouldn't more efforts be made to address these stigma in the local and regional medical schools? So, 100%, this should be core knowledge for medical students coming through really anywhere in the world. We've become a very global community, haven't we? And speaking to Canada, the racial diversity is just increasing over time. And we know that both because of the increased racial diversity and the fact that our modern medical care is better than it used to be, life expectancy is longer. Right? But that means we really need to know how to look after everyone. So it's an interesting, the answer is yes. And I think individual medical schools are probably addressing this in different ways. I can speak for McMaster Medical School. Sickle cell disease is on the curriculum. It's early on in their training. And then whether they revisit it later on depends on whether they encounter a patient or 2 or 3 or 15. I can say I'll ask Dr. Brian to comment from an emergency department perspective. The group, if you get admitted to the hospital, it's usually going to be under internal medicine. So I can say again for McMaster, it is a core part of their learning. I'm the point person for the sickle cell learning, and we were just discussing this week, I'm always weaving in issues about stigma and racism, but we were discussing this week actually making that a more formal part of their half-day session. So they spend a whole afternoon learning about sickle cell, and I'd like to make that a more central part of the goals of the discussion. Dr. Brian, what thoughts do you have, maybe from an education of emergency department learners standpoint?
Sure. So as part of their preparation for their final exam, the emergency medicine residents would be expected to develop knowledge in the area of sickle cell. That might come from their own reading. It might come from a small portion of a lecture. But other than that, just like Dr. Verhofstadt is talking about, it really comes from experiences with patients who present to the emergency department, or if they're seeking out additional information by participating in conferences, that sort of thing outside. But absolutely, there's room there for growth, right? And both at the postgraduate level, so with the residents who are doing their specialty training, and at the undergraduate medical level. Mm-hmm.
Thank you. I think that Ms. Lonry has a comment for us.
Yes, I just wanted to thank everyone that it's on this webinar today, and Dr. Brian and, Linnell are carving in Dr. Madeline for such an, impactful discussion. I just wanted to say, I think this may be a good time to also mention that our research team at Sickle, we worked on getting narratives from families on their experiences in Ontario hospitals. I think that's a huge research that is important for us to get it from the individuals themselves, what the experiences heard. So this research study has been concluded. We are now pulling together recommendations to the different hospitals that were identified by the families, and we'll be meeting with them to, as part of next steps, to understand how they want to move forward in improving the experiences of the families that have been in their hospital. So I think this study also, I believe, is helping us in Ontario to identify where we need to focus education in, where families are not getting the optimal care that they deserve. And I hope this will help to, eventually improve the experiences of our families in many of the Ontario hospitals. I think that is very important. In terms of schools, I totally believe, and I agree with all panelists, that education also begins in the schools. We have to educate the, I know many of the universities, they have sickle cell in their curriculum, but what amount of materials, of content do you have on sickle cell? That is very important. And I know we've met with the U of T, Dr. Onye Humram and her team and all of that, that U of T needs to also improve on the content of sickle cell that they have. I know there's one university in British Columbia, I can't remember which one, if it's the University of the British Columbia, which one of them. But I remember a few years ago in my prior role as a national president, we worked with them. And I believe they have a very, very strong content when it comes to sickle cell. So we can all do our part. Our doctors are linked to many of these universities to ensure that the content for sickle cell is improved, so that when these doctors come out of med school, they know sickle cell like they know cancer. Mm-hmm. They need to know sickle cell like that, right? So that's my 2 cents. I'll let you continue, Dr. Madeline.
Thank you so much. And I think, again, that's amazing that SCDAC was able to collaborate with UBC on their curriculum. It comes back again to this idea of patient and advocate input. I'll also highlight the Canadian Hemoglobinopathy Association, which has a education subcommittee, and we need to look for more opportunities to, we have the experts who are passionate about these topics, we need to be looking for opportunities to share both the experience of people who are living with this and the content, medical content experts. I see that there are 2 more questions or comments in the Q&A box, so let's go to those. So we have Natasha Morris saying, we suffer in silence because the pain alone is hard to deal with. So when in hospital and having to fight for proper care is exhausting.
Agreed.
Lynella, Kevin, do you have suggestions? What has made a difference for you if you have found yourself in those situations?
I have an advocate. I appointed someone in my family to be when I am sick, and I appointed someone. I appointed someone who will for me effectively. So when I'm at the hospital, it's my brother, and he will come in and question the right care, or if he doesn't feel the care is the right care because he's been through crises with me, he will opt it. And I'll give you an example. And Dr. V, I've told you about this. When I had to do scan for I with pains in my lungs, my chest area, and I had already been giving the morphine, and I was not really in current, right? I wasn't really with it. So my brother was there. Listen, she can't make these decisions. So how about you talk to me? We'll make it. So something like that helps me. Other than that, if I'm being bullied or discriminated against in my care in hospital, I always have like someone to call. Most times, my peers in the community will check in on me, and they will do the advocating for me. I've had Ms. Long done some advocating for me. I've had Dr. Rahosik done some advocating for me, but I've appointed someone in my family do those things when I am not well enough to do it for me, because I cannot be concentrating on advocating for myself and getting well at the. So that's what I so far.
So good. And coming, I'm going to get, I want to hear your thoughts too, Kevin, but that thought entered my mind when you were mentioning, Kevin, earlier about that steep drop off of the care and the experience after 18. And one of the things that I really strongly encourage any of my younger patients, everybody who is under my care, but somehow I don't think in that transition of care planning, it's emphasized enough. There's a lot of emphasis talking about, okay, now you're going to be independent. Okay, now you're an adult. But actually, in some ways, it's the reverse. It's like, no, this is hard. You are an adult, but adults need a support structure around them. Bring somebody with you if you're going to the emergency department, so that when you're not at your best, you've got somebody to speak for you. So I think that's such an important point. And it's hard when it takes a while to learn that on your own, like through trial and error, right? So this wisdom you're sharing with everybody who's listening in is so important. Kevin, what else? What other tips do you have?
Like in Who Wants to Be a Millionaire, I think they had a section in it where it said, find a lifeline. So you need to have a phone person, a person in front of you, and an audience member or whatever, which could be the doctor. But the thing is, as the person with sickle cell who experiences, you have a job. And your job is to explain and educate those people who are advocating for you. You need them to have the same energy that you would have. If someone is saying something that you know that is incorrect, but you're going through the pain as a sickle cell patient, that person who's advocating for you should stand up and say, no, this is what the individual needs, not wants. This is what they need. It's very important to have somebody, especially after 18 and up. They need to understand they should be talking to their wives, girlfriends, best friends, cousins. If you have a best friend, you should make your best friend the advocate for you, because they're going to fight for you much more than you would fight for yourselves at times, So I agree. I agree with Manella. That's the best way to deal with it. You need to have someone, or even have it written down. I mean, when my kids go to school, they don't advocate for themselves, it's us. And what I mean by that is we send them with a document that explains sickle cell anemia to the T. We also explain how they can contact us. We also explain weather change and everything else. So at least we have something that they can refer to. Or you should have something when you go into a hospital that they can refer to if you do not have someone to advocate. At least it's written down. And that's my opinion.
It's amazing, but it's exhausting. Yeah, so it's kind of a last ditch, when we think of a safety net, it's like a safety net, but why are there holes in the safety net? I'm going to quickly go to, there are some amazing comments and questions in here. We've got Jerome Johnson. When getting admitted to the hospital, how do you deal with doctors that tell you that you aren't in a sickle cell crisis, but it's chronic pain you're in and won't treat your pain properly? Maybe I'll ask Dr. Bryan to take that one, and then we'll maybe try to address one more after we've heard from you.
So very difficult question for a very difficult situation, right? It sounds like the interaction you're describing is one really where you're not being believed. You're saying what's happening in your own body. You're describing your pain, but that's not being accepted by the physician that you're seeing. It would be incredibly difficult to get past that kind of a barrier, to get past whatever underlies the difficulty, whatever's blocking the listening there, right? The best advice I have is really what we've just been talking about, is to hopefully have somebody with you who can help you to advocate and to push for what you need. It's a double burden when you're coming into a hospital to not only be feeling unwell, to be having excruciating pain, to be having to come into an emergency department when you would much rather be anywhere else, but to have that second burden of then having to defend the reason why you're there is a terrible thing. So I completely echo the idea about having advocates, people in your corner, about you're going to explain to the person that you're working with the best you can, trying to meet them where they are with their knowledge, which should not be your responsibility. It should not be on your plate to make the health system work the way it should. But unfortunately, for now, that's often the reality. Kevin, Lynella, did you have other suggestions? What things have worked well for you?
Oh, well, before I get into what worked well for me, I did always have a question with doctors and everyone else. As you're advocating for your sickle cell pain, yes, you asked, the doctor didn't think you had sickle cell pain. I know that was the question, but it just triggered one other thing. I noticed that also when you come in with another pain, they like to tell us that it might be sickle cell pain. My example is my son came in into the hospital and he had, I think, appendix issue or his gallbladder. I can't remember the exact thing at the moment. But they kept telling us, no, go home. That must be sickle cell because he's a sickle cell patient. I said, no, my son knows this is a different pain than sickle cell. But they always like to put that stigma saying, no, it must be sickle cell. Just go home, do what you regularly do. Here's the pain medication. Sometimes they tell you to be on blood thinners. But, if these types of pains, we need to, stop that. Stop that because you have sickle cell. It must all be from sickle cell. If we didn't go back, we wouldn't have found out that it was something else that could have affected him. Now, how do we deal with that when we go into the hospital? Again, it's a case-by-case study. It all depends on who you meet and who you greet at the front door. All depends on your energy and who's advocating for you. It's never consistent. And I guess that's our real issue is why we're here having this conversation. Just understand there is no consistency. You need to realize as a patient that sometimes it's not, I don't want to be disrespectful, or stupidity, but ignorance. It's just a lack of knowledge. We need to be able to explain to them or any individual that's giving us care that there's more to this. And I do also like to advocate to people that remember, it's a service. Hospitals, doctors, I love you guys, but it's a service. If you don't feel comfortable at one service, find another one, okay? If they're advocating for you and you don't feel this is correct, find another location. Just like grocery stores, you don't stay in one all the time, you go to others. So find something that works best for you.
Sorry, Kevin. I'm sorry, Dr. Madeline. Just to say something though, you gotta be careful with that, Kevin, because if they think that you're going from one hospital to the next hospital, that also could be a red flag that they're thinking you're looking for drugs all over the place. So if it's not working in one hospital, we're gonna make it work in that hospital. There's something called patient experience office that they do have. We're gonna have to, if you need Sickle to come and sit with them and with you, we've done that before. We're not new to that, to make sure that your experience is improved and it's optimal when you go to an hospital. I know why you feel that if it's not working here, go somewhere else. But with the limited knowledge that these people have around sickle cell, they're thinking you're also trying to get more mates there. And it might sometimes be good to let's fix it here. Let's fix it here. And I think part of the how come we're looking from the study that Sickle's doing about the Ontario hospitals is also to ensure that the experiences of individuals with sickle cell in this province will be improved no matter where they go. No matter where you live, no matter which hospital, you should be able to receive equitable access to care, right? So that is the key. We have to make sure stigma is out of the game and we have equitable access to optimal care that we're looking for in the province. Sorry, Dr. Madeline, I just have to say that.
I think I had a similar thought because it's a double-edged sword,
Correct.
That idea of you are not getting the treatment you need from a knowledgeable healthcare provider. It is so the right thing to do in that moment. But Lanre brings up a good point. In some ways you run the risk of increasing the stigma that you face. So, but each one of us only has so much energy, right? And when you're having a critical health issue, you in that moment, you need to do what's right for you in that moment. But Ms. Lanre is right. That's where you pull in the other people who have energy, who have the expertise, the experience, taking on these issues. You bring in the advocacy organizations. You know, at our center, I encourage, it's unfortunate we don't have a 24/7 helpline for our team, but I encourage anybody who's going into the emergency department during like 8 to 4, 9 to 5, call us as you're going in. I'll put in a call ahead to the emergency doctor. I'll send them over some documents so that you hit the ground running and you're not having to explain yourself, right? Or I've had, you know, people, I think Lynella included, who have been experiencing bad care in the emergency department, and they call me and we talk, and I reach out to the care team in the most diplomatic possible way, you know, assuming that they have the best of intentions, but they're spread thin, they're looking after too many patients, they don't have the experience, they may have gone into the interaction biased already. And I just reframe it for them and give them tips on how to do that. I think there's a lot of room to improve that though, because that leaves 16 hours of the day and 24 hours on each day of the weekend where it's harder to get a hold of me. So we need maybe a better system for that. But just to say, being connected in with a team that you can work well with is really important. And I'm gonna say, in response to a couple of the questions, there was a question about applying the Ontario document, the treatment guidelines, and how to make that happen. So there are some more discussions happening at a provincial level now about, and SCAGO and SCAO have both been involved in trying to apply those rules, trying to disseminate that information, make them become rules rather than recommendations. So we're working on all of those things. I realize that we are several minutes over time, and we've just barely scratched the surface of this topic. But I'm gonna give, I presume that if any of the webinar attendees need to go, they can go. I would like to give each one of our panelists an opportunity to just give some last words. We'll start with Ms. Lynella. We'll go on to Dr. Brian, Kevin, and then lastly, Ms. Lanry. So Lynella, let us know, what would you like to share as your last thoughts on this topic and discussion? You're muted.
So for my last talk, I want to touch on what Kevin said. It's like we also have different issues we go to the ER for, and I have experienced that. I've been to the ER with different issues that is not sickle cells, that was misdiagnosed, and I was treated for sickle cell disease instead. I cannot say enough that it's important when you're going to the ER to take someone with you that you know have your best interest, and that will help you navigate the system and advocate for you the way, because these things do happen to us. They happen more frequently than they should. I mean, with Kevin's experience of the gallbladder, I've experienced that. I've been to the hospital 3 times in 1 month, and they misdiagnosed me with sickle cell pain. And it's not until the absolute last minute where I had to take someone with me, because 2 times I went by myself, and I was disbelieved that the person I took with me said, "Listen, man, she's been here twice already this month. It can all be sickle cell disease. So you need to do whatever you need to do to the extent you need to do it. And what else may be the problem here?" And to lo and behold, my bile ducts was so clogged with gallstones that it was where they had to do emergency surgery just because I was a sickle cell patient with sickle cell disease. I believe that there would have been, or there was another that brought me to this ER that meant in 1 month. So it's important to take someone with you when you cannot advocate correctly for yourself. And that's my closing thought.
Mm-hmm. Dr. Brian.
Thank you. So I wanted to say thank you, first off, for involving me in this discussion today. A lot of food for thought is the expression I think that was used earlier, and that's very true. A lot of important ideas to take back. So I would hope that for everyone listening in, that while clearly there is an overlap of significant stigma and underlying racism with the disparities of care in sickle cell disease, while that's clearly been echoed by all of our speakers today, I hope that you also see the glimmer of hope as we're working together and to try to find solutions. So I know that the solutions going forward in the emergency department and elsewhere in the health system are only going to be found when we're doing this together. Right. And I think these kinds of discussions are very helpful as part of that process. I also would very much encourage anyone listening, if you need to, come to the emergency department. I know that there have been bad experiences, and unfortunately I know there continue to be bad experiences, but there are so many of us out there trying to do the right thing, trying to make things better. And if you need emergency department care, we want to see you. We want to be there and make that a safe space for you, especially with everything happening right now with the pandemic. People are all that much more concerned about coming to the emergency department, which I understand. But if you need help, we really do want you to come in and let us try to do it better than we have so far.
Amazing. Thank you. And Kevin.
All right. Well, first, thank you guys for this experience. This is wonderful. We need to continue doing these, and these are once a month. Landry's been setting them up. The most important thing is you need to advocate for yourself. The stigma is the stigma. You said something really wonderful. It's a double-edged sword. You know, I did explain that, you know, you should go to a different hospital, but yes, it's that double-edged sword situation that makes it very difficult. We as a community just need to come together. And when I say community, I don't mean a race. I mean just people of like-mindedness, sickle cell, families, friends, even other disabilities. We all need to get rid of the stigma, because that stigma that we may have, they might have it too. So we need to ask and kind of further our reach and ask, what are they doing? You know, and how did they make that change in that, sorry to use certain individual ones, but cancer or something else, right? So we need to figure that out. The most important thing is you can contact, there's so many different communities for sickle cell anemia. People need to contact us. Again, my name is Kevin Lane. You can get me at kevinlane@gmail.com, simple questions. We have a great WhatsApp group that Landry created, the Scalgo community created. It's great. You can get questions answered. And if you know anyone, be an advocate for them. Basically, let them know if you hear, oh, I have sickle cell and you're in different countries, different situations, or different places, let them know where they can streamline to come to find people like ourselves who are open-minded and ready to have that conversation with you. Other than that, thank you guys very much, and we're here for you. That's what it is.
Thank you. And Ms. Lannery, final comments and input.
I want to thank everyone, including yourself, Dr. Madeline, for being on this webinar. I know one of our board members, Ms. Doreen Alexander, is also on the line. Thank you for always having the time, Ms. Doreen, to be part of these sessions. I know it's once a month and you're always there. Thank you. I wanted to say to the community that a huge part of improving the narratives when it comes to stigma and discrimination that we experience is patient reporting. You have to report your experiences. I've had myself, I've had the experience of almost having to, more like I'm nudging individuals with sickle cell when they've gone through terrible experience to report, and they almost don't want to report. And I would say, if you don't report, how can the hospitals help improve? How do they know what they're doing wrong? You know, so do not be afraid, because sometimes it's out of fear that if I report and if I go back, maybe I'll already be tagged and maybe I won't get the good care. That's not true. So I just want to throw out there to say, if you have unpleasant experience or you feel that you've not received optimal care while in the hospital, reach out to the patient experience within the hospital, let them know. And let us know as KGO as well, because we like to document these things as part of us helping to improve experiences of patients in Ontario hospital. So again, if we don't report, how do we improve? So it all work together. So I want to encourage you, be part of that team that's gonna help us ensure every individual with sickle cell disease in this province have access to optimal care when they present in Ontario hospitals. Thank you. And thank you everyone again for being on this webinar. Thank you.
Mm-hmm. Thanks so much. There was one last question, Ms. Lanray, about the recording. When will that be available and how can people find it? You're muted.
Yes, so we will work with our IT guy to upload the recording on our website. And so give us about 1 week and we will get that on the site, and you can visit our site or shoot us an email or reach out to us on the WhatsApp forum. Also, Kevin, thank you for speaking about the forum. It's a great place. We have a lot of people from all over the province, and we have a few people outside of our province and even country that are on the forum. It's a place for you to be who you are, just to be yourself, a safe space for individuals with sickle cell, connecting with one another, sharing experiences and supporting one another. So if you're not on our forum and you think you want to be there, you're a caregiver of someone with sickle cell, you're also welcome. Family members are welcome. You can go on the website. The link to join is there, www.sicklecellanemia.ca. Be part of the family.